head trauma. Someone comes in, you see this on Grey's Anatomy and all these medical shows, comes in with an axe in their head. Do you take out the axe in the emergency room? No. Why? Because they will bleed. Meaning, although that axe should not be in their head, it's tamponading the blood. You take it out in the emergency room and they will bleed out. Where do you take it out? In the operating room. And you see this on television shows all the time. You see that they come in with whatever in them and they go to the operating room with things stuck in them and impaled in them. Very, very true. Very, very true. All right. Next, you get someone who gets hit in the head and loses consciousness and then comes back to the emergency room to be evaluated. And of course, you'll get a CAT scan on them. Now, I'm going to take an aside here and talk to you about something very important in trauma, and that is imaging. So I'm going to take a little sidestep. So follow me. Would you ever take a patient that was unstable to CAT scan? No, 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 no. But if you take a patient to CAT scan and they're stable and you're going to CAT scan the head, the neck, the chest, the abdomen, the pelvis, do you need to get a plain film in the emergency room prior? No, no. Because when you get your CAT scan, what's the first picture that they do? A plain film in the CAT scan. So therefore, if you are planning to CAT scan this patient who is stable head to toe, you do not need any plain films in the emergency room prior to the CAT scan. But if the patient is in the emergency room and unstable, then the 3 X-rays test question that you get are chest X-ray, lateral cervical spine, and pelvis. That's so important, I'm going to say it again. In an unstable patient in the emergency room, the 3 X-rays you would get are chest X-ray, lateral cervical neck, and pelvis. Now, when you get a trauma patient that comes in, the radiology technicians are there already. And they will ask you, and the nurse may ask you, Dr. Hill, do you want those 3 X-rays? The chest X-ray, the lateral neck, and the pelvis. But if you're sending this patient to CAT scan, you don't need to get those. And it's better to get the patient, if the patient's stable, to CAT scan straight away than to take the time to do those X-rays. Is it wrong to take the time to do those X-rays? No. Do you absolutely need them? No. But you want to get the patient to CAT scan. Do you understand this? Very important. Stable patient, you're getting everything in CAT scan. Unstable patient, you're getting those 3 X-rays in the emergency room. So now let's get back to that guy who got hit in the head and loses consciousness. You're going to get a CAT scan. And let's say the CAT scan is totally normal. And then the patient who lost consciousness is totally normal. Can you send the patient home? Yes, but only if they are with someone who will stay with them the whole night and are responsible. Meaning, that person has to make sure that something doesn't change with the patient. And you must always be safe. If you think that that person with the patient is not reliable or an idiot, you keep them in the hospital. You keep them in the hospital. Why? You have to be safe. You have to be safe. Always safe. Now, I want to teach you a word. When you are talking to other physicians, you do not use the word hospital. You use the word house, meaning I'm keeping the patient in the house. How many people do you have in the house? When you're talking to other physicians, the term that you use is house. Now, don't tell the patient, I'm going to keep you in the house because they'll think that you're taking the patient home with you. That's not true, okay? But you use the word house. So in this patient, if they have someone, and if you're unsure, if the person they're with is just doesn't seem responsible, you keep them in the house because you must always, always be safe. Now, let's say the CAT scan shows a depressed skull fracture, meaning part of the skull is pushed in. You got to operate on those patients, even if there's no bleeding, even if the patient seems fine. Why? Because what can happen is that injury can irritate the brain and they can have a seizure. So generally speaking, all depressed skull fractures must be operated on. All right? So now let's talk about a patient that comes in clinically with raccoon eyes, which is ecchymosis around the eyes, battle sign, which is ecchymosis behind the ear, rhinorrhea, discharge from the nose, otorrhea. Let me repeat those four things. Raccoon's eyes, ecchymosis beneath the eyes, battle sign, ecchymosis behind the ears, rhinorrhea, otorrhea. And by the way, otorrhea and rhinorrhea, what's coming out? Cerebral spinal fluid. All of those things speak to a basilar skull fracture. Good or bad? Bad, 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 okay? Basilar skull fracture. Now you might say, well, why do you need to know the clinical presentation? Well, on your test, they're going to test you on that, but you should basically know it, all right? So now, let's get into the subject of hematomas. There are two types, basically, of hematomas: epidural and subdural. Epidural and subdural. I'm going to teach you something for the test that you will need to know for the test, but clinically, you will not, and let me explain. An epidural hematoma is generally a small trauma, a lens-shaped hematoma, a lens-shaped, and a lucid interval, meaning the patient goes unconscious, then wakes up and seems fine, and then goes unconscious again. Let me repeat those three things. Small trauma, lens-shaped hematoma, and lucid interval. A subdural hematoma is large trauma. Now, guys, in clinical life, you don't have to know this because you're going to get a CAT scan that's going to tell you whether it's an epidural or subdural. But I want you to know this for the test because they're going to test you specifically on this. All right? So you get your CAT scan and you determine whether it's an epidural or subdural. The two indications for operating on an epidural or subdural hematoma are: one, shift to the midline, or two, neurologic symptoms. Let me repeat that. The two reasons you operate for an epidural or subdural: shift to the midline or neurologic symptoms. Guys, the vast majority of epidural and subdural hematomas are non-operative. I always thought that they all got operated on. Most of them go to the ICU and you watch them and you observe them and they get better. Only if you got shift to the midline or neurologic symptoms. Next, a patient comes in with trauma to their head and the CAT scan shows blurring of the gray-white interface and multiple petechiae hemorrhages. What is that? That is diffuse axonal injury. Let me repeat it. You get a patient who comes in with major trauma and they have blurring of the line between gray and white matter, and they have multiple punctate hemorrhages, petechiae hemorrhages. Guys, that's diffuse axonal injury, and that's mush. In your, conceptually, I want you to think about that as the brain is mush. Meaning, when you get a gunshot wound to the head, brain, that's what it looks like. It's mush. The patient will not survive. So I just want you to understand that. Next. You get a patient comes to you and their family says, boy, my dad is senile. And you say, well, how long has your dad been senile? And you say, oh, the past month. You think, the past month? Did your dad, get in a car accident? Did he get hit with a hammer over his head? No. But he sometimes trips and falls. Guys, as you get older, your brain shrinks. Now, just an aside, I will tell you this. Don't ever tell your children what I just told you. I told my kids when they were little, I said, when I get older, meaning me, my brain shrinks. And then whenever I make a mistake, my kids will always say to me, well, Dad, your brain is shrinking. Never tell that to your kids, okay? But it's true, as we get older, our brain shrinks. Remember those bridging veins, those veins that are in that space, they get tight. Instead of loose, they get tight and they get torn easily. So as you get older, a small trauma that wouldn't affect you young colleagues at all now will cause a bleed. And this is called a chronic subdural hematoma. And you operate on these patients, and yes, of course, they get better, but you will be the star of the day. The family will love you because you solved the problem. But remember, it could be minor trauma. At your young age, God, you could, hit your head real hard and nothing will happen. But as you get older, a small trauma can cause a chronic subdural hematoma. All right? So now we get into the neck. We get into the neck. Now, listen carefully. When we talk about the neck, I'm going to talk about the differentiation between penetrating trauma and blunt trauma. Penetrating trauma, meaning gunshot or knife, and blunt trauma, your head hitting the windshield. So let's talk about penetrating trauma. If you have a gunshot wound to the neck or a stab wound to the neck, and you have any symptoms at all, meaning hematoma, bleeding, can't talk, trouble breathing, anything at all, you're going to the operating room. They're not going to test you on that. That's easy. That makes common horse sense. The point is, if you have a penetrating trauma to the neck, gunshot wound, or knife wound, and let's say you're totally asymptomatic, you must evaluate 3 systems. You must evaluate 3 systems. The first system is the vascular system, and you would get a CT angiogram. The second system that you evaluate is the trachea, and you do a bronchoscopy. The third system you evaluate is your esophagus. Now, guys, you do not initially do endoscopy. Why? Because you don't want to put the scope through the hole and look in the mediastinum. You also don't want to use barium as a contrast, because the barium will extravasate out the hole and turn into concrete in your mediastinum. You do a gastrographin swallow. Gastrographin is a water-soluble contrast. So if you are asymptomatic, you can't just send that patient home and say, hey, bye. You have to evaluate. You got to be safe. You got to evaluate vascular, CT angio, trachea, bronchoscopy, and esophagus, gastrographin swallow. There's one exception which they're going to test you on, and you need to know. Listen carefully. If you have a gunshot wound at the angle of your jaw, and you are bleeding, you can't go to surgery because you can't take apart the skull. You can't take apart the skull. So if you have a bleeding gunshot wound at the angle of the jaw, you call interventional radiology for angiographic embolization. So now let's talk about blunt trauma. Guys, do you know what a starred windshield is? When the windshield becomes starred, meaning if your head hits the windshield and it looks like a star. Years ago, when patients would get in car accidents and they would get a star windshield, we just used to get the head CT, which was really not very smart, because the head is connected to what? The neck. Okay? So guys, when you have a patient who has blunt trauma to the neck, you always have to be safe. And I'm telling you that you should always err on the side of a CAT scan. Let me explain why. Can your lateral x-ray of the neck be normal and still have an abnormality on CAT scan? You bet. You don't ever want to take a chance. And there's an expression I always teach my residents, that pain in the neck equals CAT scan. I'll repeat that. Pain in the neck equals CAT scan. You got a patient who says, you know, doc, I got a little pain. Oh, they're getting a CAT scan. And if you're on the fence and deciding, get a CAT scan. In other words, you do not want to get into trouble by missing a cervical injury. I cannot stress this enough. All right. Next, let's talk about spinal cord injury. Now, you don't have to be a neurosurgeon. You don't have to know all the details. All you have to know is how to make the diagnosis on 3 spinal cord injuries. So let me describe them for you. They will definitely be on your test, and it'll be very, very simple. All right. Let's say someone gets stabbed in their spine, and they have paralysis and loss of proprioception on the same side of the injury, and they have a contralateral loss, pain, and temperature. Ipsilateral loss, paralysis and proprioception, contralateral loss of pain and temperature. That is called a Brown Sequard. A Brown Sequard. That's all you got to know for the test and life. Brown Sequard. Okay? Second injury. A patient's in a car accident and they have a burst injury, B-U-R-S-T, a burst injury of the vertebral body. What that means, a burst injury means your vertebral body just explodes like that. We call it a burst injury, just like that. Okay? And that patient has loss of motor function below, loss of pain and temperature below, but the posterior columns, meaning their proprioception and vibratory sense, is fine. That is called an anterior cord syndrome, meaning your posterior cord is the same. Let me explain again. A burst injury of your vertebral column. You got paralysis below, you got no pain and temperature below, but your vibratory sense and positional sense are fine, which are your posterior columns. So you're injuring what? Your anterior columns. It's called anterior cord syndrome. The third type and final type of spinal cord injury is, let's say someone has a whiplash. Do you guys know what a whiplash is? You know, where someone's neck flies back. And if they have a whiplash and they have paralysis and burning pain on their upper extremities, but they have good motor function in their legs, that's called a central cord injury. Guys, all you got to remember is whiplash hyperextension. And it causes an injury to the upper body, not the lower. It's not common nowadays. Do you know why? Because is it common in car accidents that we get whiplashes? No. What do we have in cars now? Headrests. What do we have on airplanes? Headrests. In other words, I know you can't even imagine this because you're so young, but many years ago, cars didn't have headrests. When you wanted to take a nap, you could just put your head back on your seat. But nowadays they have those headrests. And so whiplash, which used to be probably one of the most common things in car accidents, just is not common. So that's central cord injury.